Most people assume that if a treatment program has a state license, that someone is watching, someone checked, someone is making sure that the clients, residents, patients are safe. I'm going to tell you what the license actually covers and what it doesn't, because the gap between what people assume and what's actually true is where patients get hurt. So I'm referring to them as patients. The state actually refers to them as residents when they're in residential level of care or detox. They are referred to as clients when they are in intensive outpatient, outpatient, partial hospitalization. Partial hospitalization is not a recognized service by the Department of Healthcare Services. That's another topic. However, most payers will accept it under the certification for outpatient, intensive outpatient. Now that we got that out of the way, I am Dr. Angela McMahon, and I've spent over a decade licensing addiction treatment centers and mental health programs in California, but also nationally. And the Department of Healthcare Services, that is the primary licensing agency for substance use disorder addiction treatment in California. And for primary mental health, which is not going to be covered much in this video, that is actually licensed by the Department of Social Services and certified in many cases, depending on which license you get, by the Department of Healthcare Services, a different department from substance use disorder. Have I confused you enough? Anyway, primary mental health, there is no regulatory body in the state of California for outpatient. So moving on, DHCS, that's the organization that oversees addiction treatment. I have worked with analysts because I have licensed close to 100 programs and many of them in the state of California. And so I've worked with several analysts over the years, and they are fantastic. I've never had a, well, that's not true. I have mostly never had a bad experience with any of them. They're very nice, and I appreciate all the hard work that they do. And they work very, very hard. So nothing negative about the organization at all. All I'm doing is just pointing out what they oversee and what they don't. So we're back to our points like I do in every video. Point number one, what is DHCS? What is it licensed? So it's a state agency, Department of Healthcare Services. It licenses substance use disorder, SUD, residential and outpatient, also includes intensive outpatient, programs under Title IX. There are different licensing types. So you can get licensed as a residential, so residential level of care, where patients come and they stay 24 hours. And it's a non-medical level of care, although you can get certified. You can add the certification to your application for intensive, incidental medical services, IMS. But even with the IMS certification, which most programs get, it's free, unless you add it on later, but with an initial, it's free. And you're still considered non-medical. And the purpose of that is just to oversee the detox portion. And so you can also, with that being said, get licensed for detox. So most programs will get a combination of a license for a residential and detox. That gives you more opportunities to serve more people, which I think makes a lot of sense. And in the state of California specifically, most areas, not all, but most areas allow you to have up to 6 beds licensed for your residential detox. And if you choose to get 7 or more, then you have to get city approval, like a conditional use permit, and then a city business license. With 6 or less, you do not have to get a business license. Neighbors oftentimes wish that you did because there's not much they can do if they're unhappy about a home popping up next to them. So that moves us on to outpatient. So outpatient is not a license, it is a certification in the state of California. And that, on the current form, which they are updating their forms, but on the current form, there's a box that you check for day treatment. It's not called day treatment outside of that. At least I've never heard it referred to that. It's usually referred to as the way it's listed on the certification, which is if you choose to get both services, outpatient and intensive outpatient. You can do one or the other or both. And most programs will get both, but many payers per billers that I've talked to say that payers will accept partial hospitalization underneath this certification. So keep that in mind. So it also certifies programs for Medi-Cal billing. That's a separate license. It's usually done through the PACE website. So that's something totally different. Anyway, licensing and certification are two different things. Most people don't realize that. So Title IX are the regulations. You would want to look up the additional health and safety codes related to residential detox licenses. However, certification is applicable to the standards that the Department of Healthcare Services has put together. They're not as strict as what is required in a residential level of care, but they are pretty thorough. There's quite a bit there. It definitely steps things up as far as safety goes and what's expected to help you have accountability in your program. And you can also get certified as a residential detox licensed facility. You can also get the certification, which a lot of programs do, most I would say, which is great. That's great. So with that being said, I said earlier, there is no regulatory body for primary mental health outpatient in California at this time. The Department of Social Services does license mental health residential, and depending on the license that you get, like there's an adult residential facility, ARF, there's a social rehabilitation facility, SRF. If the program were to go and get an SRF, then they would also get certified by a different department at the Department of Healthcare Services regarding the SRF. Only it's called an SRP, Social Rehabilitation Program, at Department of Healthcare Services Mental Health Department. Have I confused you? Probably, sorry. But basically, the bottom line is we're sticking to what's going on with the Department of Healthcare Services, substance use disorder treatment, residential detox, intensive outpatient right now, license and certification. So point number 2, what DHCS actually covers. So this is what they're going to be expecting to see per Title IX and the health and safety codes. Physical plant requirements, like, what is the space you're using? What do the bathrooms look like? We're going to make sure that you have a fire clearance, which the fire department can also tell you how many beds they approved for fire safety. Typically, though, in a residential facility, it's 6. However, if for some reason the fire department felt that you could only safely serve 4, then they would say 4. If the fire department said you could safely serve 10, the state will still say 6 unless you get a conditional use permit. There's also basic staffing ratios. Like there's not a specific regulation that says, or standard that says you have to have this many clinicians per client. It's more the way that it's set up on the current application. Again, is that J.4, it actually says 30% of your clinical staff, so people providing direct care services, clinical services, can be licensed or certified. Licensed meaning a licensed alcohol and drug counselor, that's usually master's level, and also licensed marriage and family therapist, master's level, licensed clinical social worker, master's level. You can also be associates, and meaning that you're registered with the Board of Behavioral Science rather than licensed, and then psychologists. So for certification, many drug and alcohol counselors that are certified get their certification through CCAP or CADI, or there's a couple others, but that's usually where they go to get their certification, and they do their hours, and now they are specialists certified in substance use disorder treatment. So that's 30% of the clinical staff. This is the bare minimum, okay? So if a program wants to do 30%, then that means 70% of the clinical direct care staff can be registered, meaning registered alcohol and drug technician, a RADT. It's great. However, with that being said, there's not a lot of requirements to get that. And up until this year, like earlier this year, and I've done a whole research on what this is. So, it used to be just like a 10-hour course and basic ethics, confidentiality, boundaries, things like that. And then you could just automatically be a registered alcohol and drug technician. You were supposed to be working towards becoming a certified drug and alcohol counselor. There were all these requirements for that. But now they actually want you to not only take the course, and then you're able to start doing groups, acting as a registered alcohol drug technician per the scope of what the certifying agency says, which does include quite a bit actually for drug care services. So counseling and groups and intakes and anything like that. And the supervision is supposed to be done through either a certified drug and alcohol counselor or a LADAC. My conversation I had with CCAP, they said that licensed marriage and family therapists and licensed clinical social workers are not allowed to supervise. Now, maybe the staff member I spoke to doesn't understand what the law says, because I found a couple of areas where that might actually not be true. However, overall, that's what she's saying. She said it to me in an email. And that was a little disturbing to me, because some of the courses that the RADTs are required to take in this 80 hours within the first 6 months, I believe, it's on mental health, like studying the DSM, knowing how to apply the DSM for addiction treatment, of course. And then there are some mental health courses. So most clients, when they come into treatment, they are a dual diagnosis, meaning that their primary issue, their primary diagnosis, because it's a licensed substance use disorder treatment, has to be some sort of addiction. However, they typically also have a secondary diagnosis that's not the primary issue. It's things like depression, anxiety, post-traumatic stress disorder that also needs to be treated. Those are diagnoses that are treated by a mental health professional, like a marriage and family therapist, licensed clinical social worker, a psychologist, the registered AMFTs, ACSW, the master's level and above. And they have a specialty in mental health. So it's a little concerning that they're, per the email I got at least, not able to supervise the RADTs. I think a lot of programs do that anyway, though, but at least I know some, but they might not, they probably don't know. But with that being said, keep in mind, then a program, if they're really concerned about their budget, or if they're just really concerned about making money and not having appropriate staff, then what they can do is they can have 70% be these registered alcohol and drug technicians. Great for them. And then the 30% could be licensed or certified. A lot of times payers want the LMFT, so keep that in mind. And at least that's what billers have told me. And so from there, the regulation does not say how often that the licensed or certified person needs to be involved. So you might have them on staff. They could work 1 hour per month. Or I don't know, year. Probably not. But it I guess needs to be reasonable, but that's understood. I don't know where it actually says anything specific about that. And so, that's that. So also, DHCS does cover the policies and procedures, which need to be written per the Title IX requirements. And if you are getting certified in addition to license as a residential detox, then it has to be written to those certification standards that are applicable to residential detox as well. And that is very involved. I'll probably do another video on what that is, because it deserves its own video. There's so much to it. It is a lot. And then the same thing with the outpatient. You would write the policies and procedures that are applicable to an IOP or outpatient level of care. And there are also client rights that DHCS requires you to post in public view, and also probably in the policies. Medication management protocols per a non-medical facility, IMS if you have detox. Reporting requirements. This includes unusual incidents. It used to be what the form is called. They've updated it. But that would be things like a natural disaster, poisonings, emergency medical issue, a death, complaints. So there's a whole process that has to be followed for that. And inspections, they also do the inspection. So that's the initial site visit is what they call it, where they go around and they look at the physical property before you have your license, and then determine if you need to make any revisions or if they're just going to grant you the license. So that is one area, but then they can also come unannounced. They're supposed to thereafter. And then every couple of years, if you choose to extend or renew your license or certification, then DHCS would probably do a site visit around that time too. Or if there's some sort of complaint, usually they come out for that as well, but that's usually a different department than your assigned analyst. Point number 3, what DHCS does not regulate, and that is clinical quality. So the clinical quality is really up to the program. And I really find that actually if the organization is working with payers, oftentimes the payers kind of say what they expect the clinical quality to look like. And so, they get not really regulated, but regulated in that way. But the state doesn't really have too much of a method for really tracking that. In the initial application, there are a couple areas like continuous quality management plan and things like that. However, there's just not a real clinical quality standard that needs to be held per the license. Like they'll verify. Oftentimes I've seen analysts that will verify through a primary source that the licensed person actually has their license and it's valid and not expired. So another one is treatment outcomes. So again, part of the initial application, you set your goals and objectives, and that includes like what you expect to have for treatment outcomes, but there's not really a lot of follow-up. And the analysts, I feel bad saying this, they're just so really busy too, and it's just not a requirement to follow up on that. You hope that people are acting in best practice and that they are tracking this themselves. Now, if they are accredited, there is a standard in CTS, Care Treatment and Services, that said that you're supposed to track outcomes using standardized tool at the client level as well as the program level. So that would be for accreditation, but that's also something where the program really kind of self-evaluates and determines patterns and trends and ways that they can improve if they choose to kind of, I can get into that in another video too, but that's the idea of it. Staff training beyond minimum requirements. So Title IX does have specific trainings that are required, like housekeeping, sanitation, making sure the general understanding of addiction treatment is there, like all these different types of trainings. Also medication management, that's another one, ASAM. So beyond that, it's kind of up to the program and their own internal policies, or maybe they might also consider the other organizations, like the Joint Commission has some that they would also require. If someone, like for example, is doing a pain screen, then they would require proof of a training that that person is qualified to do the pain screen per the company's policies and procedures. So if they're a nurse and they're doing it, great, that's in their scope, most likely. However, are they doing it per the company's policies and procedures? So that type of thing. But the state is not overseeing that. I should say DHCS is not, because then you also have the labor commissioner, and then you also have the Department of Labor, which they have their own training requirements, like workplace violence, which is also a Joint Commission requirement, but sexual harassment, Joint Commission and the state, cultural sensitivity, things like that. So they're also not following up on whether a treatment model is really evidence-based. So, motivational interviewing, CBT, DBT. But again, this is probably more directed by a payer, which usually they want that. So although I will say DHCS over the last few years has required that programs get a level of care designation, which is basically an ASAM designation, American Society of Addiction Medicine. And they are required to use evidence-based tools in that area. So, but they're not following up on it, not to the extent that is really needed. So the marketing practices, that one just really gets skipped. They do have this new law where they're saying advertisements, like the advertisements standard is something that needs to be followed now, requiring what you're putting on your website, making sure you're not misleading anyone and it's accurate, honest, that type of thing. And a lot of analysts I've worked with have actually looked on the website to verify this, but outside of that, it's just not really looked at. It really takes an investigation by the FBI, which I've seen over and over again, or some other agency that is holding them accountable, like maybe the insurance, the payers, or the DEA, the IRS, the FBI. don't want to get any of that involved. So that type of thing happens on how the program recruits the residents or the clients that are coming in. So that includes like referral payment arrangements. ECRA, the Eliminating Kickback and Recovery Act, I did a video on this. That's not covered by the state. That's a federal law. And it was implemented in 2018 to prevent body brokering, basically, or marketing, paying for clients. So also, what happens to them after discharge? What happens after the resident or client discharges? A lot of programs don't really follow that. There isn't this DHCS isn't really requiring that. It's good practice, it's best practice. The Joint Commission does want you to do some follow-up, but keep in mind that when you're seeing on a website, for example, where somebody says, we have 100% success rates, what does that mean? What does that mean? Like, when are you tracking it? How do you know? I just don't understand that, because when are the intervals that you're calling them at, and what are you actually asking them? And just there are so many different factors that could impact that outcome. It can be very bias skewed. It's really hard to track that. Same thing, like if there was a resident or client death, it's easy to blame it on the disease. And maybe in many cases it is. I say this almost too much, I'm sorry, but I did lose a family member, a cousin, to fentanyl overdose. So I understand that the disease is real. I've worked in the industry for over 10 years. It's definitely real. It's extremely sad. A lot of times it is a disease. Sometimes it's not. So let's talk about the provisional license, which is programs can operate and admit clients under a provisional license. So provisional means that the state has not yet fully verified compliance. Yet what happens is if you're an initial residential license or certified residential detox, then the state, if they approve you, then they will grant you a 1-year provisional license, although it expires in 2 years. And the idea is that they will be unannounced and stop by within 6 months to a year. I'm hearing from a lot of places that they're stretched thin and it's just not happening. So if it goes beyond the provisional date, payers sometimes have an issue with that. And what I've been told is to tell them to use the letter that comes with the provisional license stating that they're, basically good to go still. So, but again, a way that you could find out if a program is a low quality program, I guess, would be if there was a client that complained or family member, there was a complaint made, then DHCS would do an investigation most likely. So keep that in mind. Okay. And the public has no easy way to know a program is provisional or fully licensed. So the license is usually it's hung in public view at a program, usually near the front door or somewhere where people can see it. However, knowing if it's provisional or not, that would take some effort to figure that out beyond looking at the license in the door. And that doesn't mean that they're not a good program. They could still be a high quality program under a provisional license. I help with that all the time. And I know quite a few that have done very well under provisional license. They can't skip that step. So there's nothing they can do, like whether they're a low quality program, high quality program, they'll get a provisional license. So, and DHCS does publish a license program list, but it's complicated. It's not easy to read it. Even someone like myself who specializes in compliance and works with these regulatory agencies all the time, like regularly across the nation, I'm still like, how do I find what I'm looking for here? Why is Control F not working? So yeah, walking through it and teaching viewers how to use it isn't the easiest thing. Point number 5, what this means for residents, clients, and families. A DHCS license is a floor, not a ceiling. It tells you the program is allowed to operate legally, but not that it operates well. Ideally, though, in order to get the license, you would assume they operate well. So complaints to DHCS can trigger investigation. Timelines could be slow. Programs can accumulate deficiencies and continue operating. The public has no real-time visibility into the program's compliance history at this time. There are some agencies like, it's supposed to be public record, some of these reports. So you could probably access it. It's just not easy. It's not easy. Accreditation fills some of this gap, but not all programs pursue accreditation. And again, like I've said in other videos, even with accreditation, it doesn't mean that it's problem-free. So a license is not a guarantee. It's a permission to operate. The gap between those two things is significant. And in addiction treatment, that gap, it has consequences. So California has definitely made a lot of improvements over the last few years. I mean, they have made so many amazing improvements to its oversight framework. However, the structural limitations of what a license actually covers, it still remains, knowing that the first step really is asking really good questions. So that's what I'm here to do. I'm trying to be a hub where I bring all of the compliance knowledge as well as the fraud knowledge and research that I've done and make it really easy in one place. So right now it's kind of like you hear about a fraud here and there in different communities. One pops up, they cover it locally. I think this is a systemic issue, the buzzword, and that it really should get more national coverage because this is something that people do die from and it's serious, and families need to know where they're sending their loved one. They need to vet them properly. And a low quality program and a high quality program, when that admissions person's on the phone, it can sound the exact same. So we need tools to figure that out. Subscribe for weekly content. And I'm doing a video every Tuesday. Thanks for watching.